minutes, I think. Hi there. I'm Andrew Shannon. I'm the ultrasound director out here at Lakeland Health Emergency Department in Central Florida, rainy Florida today. Welcome to the combined ACEP and SAEM Journal Club, Virtual Journal Club, Probing the Literature, or PTL for those in the know. This is January 2024, and so we're actually going to be hitting our topic today of OBGYN studies as content, and we're going to actually start off with our first article. Our presenter is going to be Dr. Sara Urquhart, and she's going to be presenting her study on, on whether or not point-of-care ultrasound in the emergency department decreases the time to surgical intervention for ruptured ectopics. Dr. Urquhart is currently, if I'm not mistaken, still a resident at Detroit Receiving, and interestingly, was so during this study period. So we're interested in talking about that. And also her bio includes being one of the graphic art directors for the Ultrasound Gel podcast. So a lot of talents to get into, and hopefully we'll have a good discussion there. I'll hand it over to you, Dr. Urquhart, to give us just a quick kind of walkthrough of the article, and then for the benefit of everyone, we'll just chat about a few different things and potentially your research experience and there so that we can glean wisdom. So I'll go ahead and hand it over to you. Take it away.
Thanks, Dr. Shannon. Hi, everyone. Thanks for showing up today. I'm actually coming to you from just outside Detroit. My kids are home for a snow day, so even if it's rainy in Florida, it's probably warmer than it is here. I am a second-year resident at Detroit Receiving Hospital Emergency Medicine Residency, and just to clarify, I did the work for this research article while I was a medical student at Michigan State University College of Human Medicine in Grand Rapids, Michigan. So I'm joined by my mentor and co-author, Matthew Flannigan, who is the ultrasound fellowship director at Spectrum Health or Corewell Health in Grand Rapids. So we can both kind of help tackle any questions about our article. The original idea for this research work was from one of, I don't know, Matt, what number ultrasound fellow Mariah Barnes was, but she was the ultrasound fellow in 2018 when I was a first-year medical student. So I started getting involved with the research projects with Dr. Flannigan and the fellows, and did so throughout my medical school career. But this was her project for her fellowship. So when she started fellowship, she actually wrote several, impressively, like 3 or 4 IRB projects, much more than I think the typical fellow does. And much like many ultrasound fellows, didn't get through all 4 or 5 or however many projects she had thought of. So when I expressed interest in helping with research, with emergency ultrasound research, there were these kind of projects like already approved by the IRB at the hospital, but needing the work to be done. And I think we completed and published 2 of the studies that Dr. Barnes had come up with, and this was one of them. And it involved retrospective chart reviews. And at the time I did all of the retrospective chart reviews together with Dr. Barnes. So it was very fun for me as a medical student to read through the charts in Cerner from emergency department stays of patients who had been diagnosed with ectopic pregnancy, and then get a chance to kind of look at their ultrasounds, because I knew this was my intended area of specialty going into medicine. It was my first ever endeavor in research, so I had to do a lot of reading and learning along the way, and I collected the data in a Microsoft Excel spreadsheet, I didn't have any like really impressive software to use for analyzing the data. I got like a free trial of like um, um, analysis software for 1 month in order to make my figures for the article. And I submitted it 5 times I started with Annals of Emergency Medicine and worked my way down the impact factor before I found a journal that was willing to publish it. So everything from, I didn't like originate the research idea, but after that, everything, I led it. I mean, obviously didn't do all the work myself. Dr. Flannigan and Dr. Barnes were excellent mentors, but I had to learn everything along the way because I was, doing that. So I love to talk about the research process that I went through, just if it's inspiring to other people, if they have questions. And then, of course, we need to talk about the article and what it was about. But what's your first question for me?
I think that's a great intro. There's so many bits there about folks who are trying to get into research and sort of saying like, hey, how does this work in? And so certainly finding someone who's willing to be a mentor for you, finding someone who's sort of like willing to take you on and let you run with something, that sounds like a great opportunity. You knew kind of going that you were interested in emergency medicine, interested in ultrasound specifically, and so you just sort of said, "Hey, who does ultrasound here?" and looked around and sort of got into a project. And Dr.
Yes,
Flannigan found someone who would work, and so put you to work.
exactly. I was an emergency nurse before medical school, and I had worked in a rural emergency department where no one did ultrasound. But I started following some medical things on Twitter, and so I heard about POCUS and piqued my interest even while I was a nurse, and started asking like, why are we not doing an ultrasound before I started medical school? And so as soon as I could I shadowed a emergency physician, and I remember asking her like, who's the ultrasound person here? And that's how I got Dr. Flannigan's email. I just emailed him directly. It's probably kind of strange, but something you're passionate about, like just kind of go for it, I guess.
I've definitely heard the sound of scientific progress is, huh. And so that's where all curiosity starts. So you mentioned this is your first project. And so you contacted Dr. Flynn and he said, hey, there's this project. We need you to do this chart review. And this is sort of getting into the article a little bit, but it's something that we see quite a bit in particular, just to sort of give a little bit of framework here if, for the one person on the call who hasn't read it. So this is a retrospective study. So starting kind of at the end with the diagnosis of ruptured ectopic, and then sort of doing the chart review to sort of see, kind of how the folks compared from the point of view of the point of care ultrasound versus the radiology ultrasound. So you're doing a chart review, and that's sort of like the methodology portion of it. And, it's like, how do I get this information in the least biased way possible is sort of, the crux of a retrospective review, right? One of the things that I'm curious about, probably just on the ground point of view, is you'll see a lot of these studies will have the standardized data instrument or the standardized data tool. Where did that come from for you guys? Was that something that you had like a sample rubric to be based on? Is that something you sort of just workshopped and decided, hey, this is how we're going to look for these different things as we go through the chart? Or where did that tool come from to help you as you went through your chart reviews?
So for the retrospective data review, we had I think it's called an honest broker, and they went through all the ICD codes for anyone who was diagnosed with an ruptured ectopic pregnancy or ectopic pregnancy, because we didn't want to miss any patients, since ICD code input isn't always perfect. So I actually went through a lot of charts of patients who were not ruptured. I had to actually like go and look at the pathology report from the operating room note. The standardized data abstraction tool is like a pinnacle of retrospective data research studies, as you said, and I didn't design it. Dr. Barnes and Dr. Flannigan had already designed it when I came on, and it was the Excel spreadsheet. But it looked a lot like probably what Dr. Moore used for his study, the other paper that we're going to be reviewing. I think that they did an excellent job figuring out what would be interesting to think about in terms of people who had had a ruptured ectopic pregnancy, in terms of how many pregnancies they had in the past, how whether they were using IVF, what chief complaints they had. I mean, and there were, a lot of data points that we abstracted. And one of the important things to do when you're getting your IRB approval and starting your study is to put as many things as you can think of, because you can't add things to your data abstraction tool, but you can like gray them out. So, say you wanted to collect race and then later decided that wasn't interesting, like it's important to just think of as many possible things as you can that you want to abstract from the charts so that you can get that approved by the IRB. Because once you have that data abstraction tool, it's, I think, pretty much against the rules to add. You can't then be like, oh, now I want to collect this extra data about people. Because you're doing human subjects research, you have to declare what information you're going to be getting out of the charts about the people. So there were a lot of things in the spreadsheet. And I don't know, Dr. Flannigan, if you remember developing the data abstraction tool with Dr. Barnes, if you used any other sources to make that.
No, not that I remember. I think that we had read several articles about ruptured ectopic pregnancies, or just OB articles in general, and just had a general idea of what kind of information we thought would be relevant, and just started putting it on an Excel spreadsheet, and that was it. So yeah, I just wanted to mention that, Sara has kind of a deep history with Michigan State University in terms of how influential she's been with getting an ultrasound elective started at the med school, with instituting a medical student ultrasound research group that is still ongoing after she's left for residency. So she's very bright, very motivated. She's been incredible. It's been an honor to be a mentor to her and to be a part of her career path.
That's great. It can't be done until someone does it, and then all of a sudden, oh yeah, and then now so much follows. Awesome. I just wanted to talk a little bit more about the study. So you looked at all of these different patients, started with, it looks like 262, came down to, okay, there were 36 that were ruptured, and then eventually went down to the 32 that were enrolled. And then sort of looking backwards, starting from that point, which in a retrospective way, if it's a rare diagnosis, sometimes that's the, a better way to do that is to sort of find the quote unquote, I don't want to use the word cases because that can get confusing, but find the outcome of interest and work your way backwards. And then 10 of those had the POCUS and 22 had the radiologic performed ultrasound. And then as you go through, you have on that, excuse me, that table there, very clear kind of time difference when it comes to when the ultrasonographic diagnosis was made. And then that time difference kind of persisted when you're talking about OB consult, OR time, all that other stuff. So it really certainly suggests strongly that getting the diagnosis as early as you can changes these people's time to the OR, which was a great outcome, as opposed to some of the other things that, like patient mortality or blood product or a bunch of other difficult things. But that's such a clinically important outcome, time to OR, from our point of view. That was great, super well chosen. in terms of, as you're going through this data, or as you were sort of thinking about kind of where some of the weaknesses or some things that you wish, either with, more time, money, more research assistance, what things would you have wished that you might have looked at or might have started to include, or some things that you might have tried to look at differently when you're going through these patients' journeys?
I think one of the things I didn't know, and a lot of things I didn't know until the end, until I was writing the paper and reading all of the rules about the things you have to report in a retrospective study in order to get it published. One of the important things to do is the internal validity. So having multiple people do the chart reviews and then comparing to make sure that that everyone's abstracting the data in the same way. If you're abstracting quantitative data, it's a little bit less likely that people are going to get different numbers. But when you're abstracting things like, did the patient complain of abdominal pain? Or, did the patient have prior IVF? You need to make sure that everyone's looking in the same parts of the chart to abstract the data correctly if you have multiple people abstracting data. And the other thing that increases the validity of your study is having multiple people abstract the data. So if only one person is doing the data abstraction, then you're putting your study kind of at risk of bias of that one person. So having multiple data abstractors and then publishing an internal validity number by, choosing, I think it's like a percentage of the number of chart reviews you did, but at least 10, 20, and comparing them and getting a number for that is something that I wasn't able to do because I did probably 90% of the data abstraction by myself. And then it was too late to go back and do like an internal validity. So if I did another retrospective chart review study, I would kind of design that from the outset. Obviously, if I had more money, I wouldn't have done all that data abstraction myself. And it had to be done manually. I know when I read retrospective papers, I always wonder how they get the data. There's a lot of like big, huge data sets that people just are able to abstract a ton of data out of, like using electronic means. But this was like, I literally opened an old version of Cerner because they had switched to Epic and opened every single chart multiple times. And then I had to also open with their like MRN number in the ultrasound database as well, because that's separate. The point of care ultrasound stuff is not in the same place as the patient's charts. So that took a lot of time.
And advertisement for Epic notwithstanding, does anyone sort of in the group have any thoughts or experience about that in terms of like that abstraction, data abstraction challenges or successes? Certainly, the one of the points of having that standardized form is to try to say, hey, yes, it was one person, but this is the way we did it. We did it this way every time, or I did it this way every time, as sort of like your abstraction Bible to refer back to, so that's a big part of it as well. But that was a great point in terms of this is a lot of it, it's not work where you have to depend on patient response to surveys, but anyone else have any other thoughts? I see yeah, it looks like filtering through Epic and REDCap a little bit easier than manually putting into an Excel spreadsheet or filtering with some of the other workflow solutions I'm seeing in some of the chat.
And medical students are great for abstracting and and training, like you mentioned, is super important so that you have really specific instructions for people to follow. Because if you don't and people are doing their own thing, it's going to be just a complete mess. speaking from experience. So yeah, that instruction and double checking is like really important, and even doing like a test set to make sure that everybody's doing the same thing before you do your actual data abstraction can help make sure that you have that internal validity.
Forgive me for having not going too deep into the supplemental materials, but was the data sheet, the data collection sheet, published in the supplementary materials for this one? Great.
Yeah.
And I'll just share one experience too that I've had with this data abstraction thing is like you get halfway through and then you realize there's this like other data point that you want to abstract, and you have to like go back and start all over again and open all the charts all over again. So making sure early on that you have all the potential information that you could want to get, because it's like a lot of the time consuming part is like actually like typing in the MRN and opening the chart. It's not actually like getting the information. But if you have to go back and do that all over again after you've done, 100 charts or whatever, it just makes it really frustrating.
And that, yeah, certainly from the IRB point of view, in terms of you want to be doing it the right way, but also from the, again, internal validity point of view of like, it's like, hey, this is also interesting. Like those kinds of things, again, can introduce variability or bias in terms of what you're looking at. And now all of a sudden you're looking to try to study something else. So that first session, the no bad ideas session of brainstorming, what are the things we might be interested in, how, this tool that we're looking at. And I think in the paper, there's actually a series of references that I suppose Dr. Flannigan and so on went through to say, these are the kinds of things that have been done before. These are the kinds of things that seem to be important. We're going to at least include some of those. And are there other things? And sort of going from that point forward. I'll say in terms of, just being a little bit of a stats nerds, the stem and leaf plot, all that sort of fun stuff just warmed my heart as I was looking at it. But what I really loved was that figure 1, sort of throwing in that flow diagram of from left to right of this very clear retrospective. This is sort of how we did it. And these are the patients that fell out of our selection process. And these are the patients that we, included in our selection process, and sort of tracking that out. Because with these things, the selection bias is so central to whether or not the study is worth anything, that sort of accounting for why people were included or excluded at each step is really sort of the meat and potatoes of the research. So I thought that was visually kind of very nice. Having just finished some charts from last night, I do sort of worry about the fact of using the electronic medical record timestamp as sort of when we also called OB, because I've definitely been in a situation of putting in a phone call and then putting the consult order in after I've, started the level 1 transfuser or whatever else. So there's always that kind of level of variability, but there's not much you can do about that. That's, you have to go with what's in there, but there's always that wiggle room for people who actually practice, for sure.
Yeah. I had a question about one of the outcomes, and it was the time from interpretation of the ultrasound until the time of interpretation of the ultrasound to the time of either the OR or diagnosis or to consultant. Now I can't remember. I have to go pull it up again. But it was like much longer in the radiology versus the emergency medicine, and I couldn't quite figure out why that would be, like why there would be a difference between when the result was resulted and how soon they got. I think it was to the OR. I have to go pull it apart.
If I can, I think it looks like, so of the 22 radiology reports, the time to diagnosis was 138 minutes compared to the POCUS's, which was 15 minutes. But then the next sort of data point was the time to consult. And then that from ED arrival is still total time. So the time to,
okay.
Yeah, so that significant difference includes that 138. If you subtract those first numbers out, then it's about 20 minutes from diagnosis to consult for each group, if I'm reading that correct. So the big time save was presentation to diagnosis. And then it seemed like consult to OR happened pretty quickly, similarly after that. Is that a fair read of what we're seeing?
Yep, that's perfect.
Okay.
Yeah, because you've got all that built-in time, and that's the beauty of why we do point-of-care ultrasound. It's like you order the test, and then you got to wait for the tech to do the test, and then you got to wait for the radiologist to read the test, and then transcription time, and then you finally, read the diagnosis that the radiologist has before you're reaching out to the consultant.
Yeah, I'm also curious about the flow of that. So, I mean, we get if there's a critical finding, we get a call from the ultrasound, the person who's reading, like immediately. So we don't have to like wait for the transcription and all of that stuff. So I'm just curious about, how that was communicated. And yeah.
That is not typically done. The ultrasound tech may reach out to the radiologist may then reach out to us, but that wasn't always the case.
Okay.
It certainly is a little bit different at the smaller regional hospitals, where you kind of have an intimate relationship with the ultrasound tech, where they're coming into your department to grab the patient and also bringing the patient back. So they might be more willing to kind of share that information. But at our level 1 trauma center, typically the ultrasound techs don't communicate with the attendings in the emergency department, but they would with the radiologists.
I want to make sure that we're mindful of the next session as well, but I did have, did someone else have something? I had another question on the other end of that, which was, you mentioned that your program has a pretty robust POCUS training program. What is the response of your OB/GYN doctors to this ultrasound was done by us in the ED as opposed to radiology? It certainly seems like they said, okay, let's take it. Is that sort of the expectation or culture there?
Yeah, I'm sure our program is similar to other residency programs where there's been kind of an evolving skill set that more residents and attendings over time have become more competent in, making the diagnosis, reaching out to a consultant and having the consultant act on their interpretation. But one of the major factors for us was implementing QPath, and that corresponded with 2012. So the ability to get images into the PACS system and a report into Cerner and now Epic was huge. Prior to that, you could tell them anything that you wanted to tell them, but they didn't really want to act on bringing the patient to the OR until they had something else where it was actually documented somewhere else, that you had an interpreting physician making the diagnosis before they brought them to the OR. So that's the same for our FAST exam for ruptured AAAs and then ruptured ectopic pregnancies. It's really transformed our communication with our consultants.
For sure. Awesome. And then my last question for Dr. Urquhart, before getting into this, did you realize how many hours it took to do a project that was as simple as this?
I didn't know, I guess, what I was getting into, but I really enjoyed the project, like as a medical student. So I guess if I would be able to give advice to like all the people here who are ultrasound fellows, I think you can really sell a retrospective project to some medical students. If you teach them really well how to do the chart reviews, I personally really enjoyed it, and it helps me write my notes now, to read all of the notes, and I really enjoyed going through the charts because I kind of at least had this sense that I was, seeing patients and, learning about emergency medicine. It was nice. I was required to do the chart reviews from the hospital property, and I was allowed access to the ultrasound office to do the work, which really kind of made me feel special as a medical student. So I think you can get yourself a couple medical students who are interested in ultrasound or emergency medicine, and be able to develop a mentorship relationship. And it's a very like mutually beneficial endeavor. And if you want to study something like ruptured ectopic pregnancy, which is so rare, you can't really do a prospective. It would take you years to enroll the right number of patients. So, or you'd have to have so many different sites. So picking some sort of like rare thing and looking up the charts, that over the years, to study, what the outcomes are or how we can improve or prove that ultrasound is helpful in some way. For me, like being able to declare like publicly and like being approved by publishers to say like ultrasound helps make this diagnosis faster and make the outcome, not necessarily the outcomes, but make treatment for the patients with this disease process better, was like very gratifying. So that's why we study ultrasound. I guess that's hopefully why everyone's in the fellowship program.
Well, great. Well said. Thank you for talking with us today. Thank you for, putting in the grind and getting the research done. This was a great paper. Someone on our team was just saying, I use this all the time. I'm actually really interested in hearing what she has to say about it. So fantastic.
That's great to hear. It's really, I was really kind of surprised and honored to be chosen to speak at. I remember attending these a couple years ago when I was in medical school.
Well, happy to have you back anytime. So thanks very much. Dan, I think, yeah.